Thank you very much for asking me to speak. My name is Sam Dawkins. I'm an interventional cardiologist. You've already heard from Jim Newton. He and I run the structural program in Oxford. I've been asked to talk to you about transcatheter interventions in tricuspid regurgitation. Why is this important? Well, tricuspid regurgitation is a really debilitating disease. Patients feel terrible with it. Tricuspid regurgitation is associated with reduced cardiac output, which leads to fatigue, weakness, and reduced exercise capacity. And you're all familiar with the symptoms of right-sided heart failure. In the earlier stages, patients feel congested due to venous engorgement. They then develop hepatosplenomegaly, peripheral edema, and ascites, and in the later stages, cachexia and jaundice. As with our experience of managing other valve pathologies percutaneously, patients often don't quite know how bad their symptoms are, and it's very striking. Once you treat these patients, they feel dramatically better and very quickly. Tricuspid regurgitation is extremely common. Here's a slide from the Oxford community study of a selection of patients who do not have a diagnosis of valvular heart disease. And in those patients, you can see that significant tricuspid regurgitation is the most common undiagnosed condition there, more so than mitral or aortic valve disease. I think pretty much every tricuspid regurgitation presentation there is has this slide. This paper just shows the natural history of patients with tricuspid regurgitation. You can see that the survival for patients with severe tricuspid regurgitation is 63% at 1 year. That kind of figure is not that far off the survival from secondary mitral regurgitation. So severe tricuspid regurgitation is associated with a very poor outcome. Leaving patients with tricuspid regurgitation after mitral valve intervention is also associated with a poor outcome. In this case, this is residual tricuspid regurgitation after MitraClip. And here, residual tricuspid regurgitation after mitral surgery is showing a reduction in right ventricular function in this group of patients. Tricuspid regurgitation is very undertreated. Here is some data from the United States. You can see that aortic stenosis is proportionately the most treated pathology, mitral regurgitation next, and tricuspid regurgitation is barely treated at all, despite being very common. I think this is a really interesting slide. This is data from the Society of Thoracic Surgeons in the United States looking at isolated tricuspid surgery over a 10-year period from 2004. And the scale on the left really is hundreds. So what you're seeing is that the number of procedures for isolated tricuspid repair are very, very small, with 5,000 procedures over 10 years. And despite the 10-year analysis, the mortality has remained pretty much the same at around 8 or 9%. Compare this with the data for mitral repair, where there have been 90,000 procedures over 5 years with an operative mortality of 2%. So if you put the two together, you can see that tricuspid regurgitation is very, very undertreated when it comes to surgical repair or replacement, with considerable inpatient mortality. The etiology of tricuspid regurgitation is different to mitral regurgitation. Most of it is secondary and most of it is related to left-sided valve disease. The primary mitral regurgitation that we see is largely related to pacemaker leads, and that factor makes treating this particular phenomenon a lot more challenging. There are other less common disorders that can also cause primary tricuspid regurgitation. Part of the reason that tricuspid intervention, percutaneously at least, is challenging is because of the complexity of the anatomy of the tricuspid valve itself. It obviously has 3 leaflets, which makes leaflet repair much more difficult than leaflet repair in the mitral position. The other issue is the 3D anatomy of the tricuspid valve, which is perhaps not as well understood. It's saddle-shaped and becomes flatter as the right ventricle dilates. The other consideration in the right-hand panel there is the way the right ventricle dilates. It dilates away from the septal leaflet. And that means that if you're attempting leaflet repair with a MitraClip device, for example, you tend to clip the septal leaflet and one other. So you tend to clip septal to anterior or septal to posterior. Because of the way the right ventricle dilates, you tend not to clip the anterior and posterior leaflets together. Why is transcatheter tricuspid repair difficult? Well, there are lots of reasons for that. The tricuspid regurgitation jet is often very broad, much more so than we see usually in mitral regurgitation, which means that fixing it can be difficult using just a single device technology. They're quite often broad and multiple jets. The leaflet anatomy is highly variable. It's quite common, for example, to have 4 leaflets, and the size of each leaflet respectively is also highly variable, although usually the anterior leaflet is the largest leaflet. The leaflets themselves are very delicate. If you've ever seen them in surgery, they're paper-like. There is also the issue of leaflet abnormalities. The leaflets can become tethered exactly as you see in the mitral valve in ischemic cardiomyopathy, for example. You also get leaflet prolapse. Most primary tricuspid regurgitation is caused by pacemaker leads, and that issue can either be that the pacemaker lead is splinting the septal leaflet open, but sometimes it's actually attached and scarred onto the septal leaflet, which makes leaflet repair challenging or impossible. For tricuspid valve replacement technologies, it's important to consider the other structures around the tricuspid valve. The right coronary artery encircles the tricuspid valve annulus, so compression of that is a really important consideration with tricuspid valve repair. Conducting tissue is also very close to the tricuspid annulus, and that also needs to be considered. But none of those are the major issue with tricuspid repair from percutaneous approach. The major issue is imaging. The anatomy is very complicated, and I don't know about you, and I'm sure we'll talk about this in the discussion. I have always thought of tricuspid regurgitation as being there or not. You don't really think so much about the anatomy of it. But once you start to think about the anatomy of it, working out which leaflet is which, having standardized views, configuring the views in a standard way, for example, using 3D views always in the same orientation, as we now know to do for mitral imaging, all of those things can make understanding the anatomy quite difficult. The tricuspid valve is far away from the TOE probe, so imaging the leaflets, which themselves are very thin, can be very difficult. The other issue is shadowing, which is a real issue with, certainly with leaflet repair with coaptation devices. Pacemaker leads, of course, cause shadowing. Patients who've had any procedure in the aortic position, such as TAVI or surgical aortic valve replacement, those devices do cast shadows and can make it impossible to see the tricuspid valve leaflets. Finally, the effect of the tricuspid device that you're using to repair or replace the valve is very difficult to predict the impact that shadowing will have until the device is actually there. So you may have a patient who has fantastic tricuspid images, but as soon as you've got a mitral clip device, for example, in position, you just can't see the leaflets, and that makes repairing that valve difficult or impossible. So what technologies do we have available to us? I wanted to just talk through some of these and give you some case examples, just to give you an idea of what we have now and what might come to us in the future. Essentially, just like mitral valve percutaneous technologies, it's down to replacement or repair. So for repair, it's either leaflet repair, which is generally with a coaptation device, such as a mitral clip or a Pascal, annuloplasty, a spacer device. And then when it comes to replacement, it is either a case of replacing in the same position, that's orthotopic replacement, or in a different position, that's heterotopic replacement. And we'll just talk through each of those in brief, and then we'll go through some cases. Replacement with a valve in the same position has been making quite a lot of progress recently. I think a lot of us always hoped that in the mitral position, there would be a device that would be as effective as a TAVI valve, and that we wouldn't have to mess around with repair, which is obviously a lot more technically challenging. That really has not proved to be the case. I suspect that is going to be true also in the tricuspid position. I suspect replacement will be the treatment of choice for patients where the valve is not repairable. The issue being that the right heart is a low pressure, low flow system, and there is a real issue with thrombus on the leaflets, and patients with tricuspid valve replacement are likely to need oral anticoagulation. That is a major Achilles heel of tricuspid replacement technologies. Where they are useful is for patients who don't have repairable valves. So those patients perhaps with pacemaker leads welded to the septal leaflets, patients with rheumatic disease, very curled and restricted leaflet tips, for example, and those with very large coaptation defects. This is the Evoke device, which is from Edwards. The animation is actually in the mitral position, but what you can see is a bioprosthetic valve which uses the annulus and the leaflet tissue as an anchor. And you can see that it has these feet that essentially grab onto the leaflet, which in the mitral position is obviously useful because it reduces the risk of SAM and left ventricular outflow tract obstruction, but also provides stability. And then the device flares into the left atrium in the case of this animation to minimize the risk of a paravalvular leak. Now, this kind of device, this device has been used relatively widely in the mitral position, and there's a study going on at the moment looking at the device in the tricuspid position. So here's an Evoke device in the tricuspid position. You can see here a really excellent result, the left hand before shot showing torrential tricuspid regurgitation with none in the right hand after picture. So that's a device that's showing early promise. The Navigate device is delivered via right atrial access, so it's a surgical approach, and that uses a slightly different design to anchor at the tricuspid valve annulus. And anchoring these devices at the tricuspid annulus is really the key to the success. The tricuspid annulus is very variable in shape and size and also three-dimensional shape. So making sure the device is secure is one of the real design challenges for these devices. So there are some examples of the orthotopic valve replacement devices. The heterotopic technologies, so putting a valve in a different position, are at an earlier stage of development. There have been some case reports of SAPIEN 3 in the IVC inside a vascular stent, which is a neat idea to reduce the features of hepatic congestion related to tricuspid regurgitation. Another device which is quite interesting is a bicable device. This device uses two valves. So the first valve is deployed into the superior vena cava, which obviously has an impact on the congestion features that patients feel with elevated jugular venous pressure and feeling essentially bunged up, which tricuspid regurgitation patients will often talk about. And then a second valve is put in the inferior vena cava to address the hepatic congestion features. So that is a neat device that is in a fairly early stage of development. Moving on from the replacement, we're now on to the repair technologies. One technology which showed some early promise was a spacer device. This device is called Forma, and it essentially occupies space within the tricuspid valve annulus, and the tricuspid valve leaflets then oppose against the device. So you can see that essentially it addresses an issue with patients who have a very large coaptation defect. Now, the early study into that device, which I was involved with, was promising with an impressive reduction in tricuspid regurgitation severity. The device is quite challenging. There were some issues with damage to the right ventricular apex, for example, and in fact that program has been put on hold for the time being. Moving on to annuloplasty, as you know, one of the major issues with patients who have severe tricuspid regurgitation is annular dilatation. There are various devices that have been used. What you can see on the screen there, top left is the Mitraline device, which is a pledget device, that's no longer available. That was a pledget device for annular reduction. Next on the right is the Fortec device, bottom right is the Cardioband, and bottom left is the Millipede device, all of which have been used in the tricuspid position. This is the Fortec annuloplasty device. Essentially, the Fortec delivery system allows you to deliver a little coil which sits outside the right ventricular free wall and is used as an anchor. And that anchor is used to pull together the annulus, so do an annuloplasty with a stent at the other end of the anchor, which is deployed in the inferior vena cava. That certainly showed early promise, but that device is no longer being developed. The Cardioband device is another annuloplasty device which is delivered femorally, and that device essentially is screwed into the annulus, gives an annuloplasty which can then be tightened to reduce the annular dimensions and hopefully therefore reduce the tricuspid regurgitation. As you can see, the annular ring is delivered in stages with a screw at each bend, and the whole device can then be cinched. And that brings us to the group of devices that have perhaps the widest experience, and that is the leaflet repair devices. So MitraClip, it has been around the longest, well over 150,000 cases done worldwide in the mitral position, and is now gaining traction in the tricuspid position. I was involved in some of the early cases with NT in the tricuspid position, which was extremely challenging because the leaflet arms were not particularly long, and also the guide is not designed for use in the tricuspid position. The TriLuminate study uses a slightly different guide, but the same clip, and that was an order of magnitude more straightforward. Most of my experience is with the MitraClip XTR, so that's with the standard MitraClip guide and the longer clip arm version of the MitraClip. That's easier still. And the new device, the TriClip device, which is now CE marked and being rolled out across Europe, uses the XTR clip, but a specialized guide, which is designed for the tricuspid position. I just want to give you a brief idea of the TriLuminate study, because I think it is important, because one of the key points that I raised early on is that the mortality from isolated surgical repair and replacement of the tricuspid valve is very high. 8.8% was the number I gave you from the STS database. The TriLuminate study recruited some pretty comorbid patients, and the really important point here is that the implant success rate was 100%. These procedures are not actually that long. They're 75-minute device time, for example. Here is the reduction in tricuspid regurgitation, with most patients having a 1 or 2 grade reduction in tricuspid regurgitation. And what is really striking is that even with quite a complex group of patients, the 6-month mortality was very low, with a major adverse event rate of 3.7%. Compare that, so bear in mind that's at 6 months. Compare that with an 8.8% in-hospital mortality for isolated tricuspid valve surgery. And this is a very early study of this particular technology. Here's just some more data to show that the result that they got in this study is durable and that was associated with symptomatic improvement. I think this is something that anyone who's been involved in these technologies will know, is that you don't need to obliterate the regurgitation. Just taking a grade or 2 off is enough to make patients feel a lot better. Just to give you more contemporary data, bear in mind the TriLuminate data, which I showed you, is with the NT clip, so it's with the clip with short clip arms, which is quite difficult in the tricuspid position. This is using the Pascal device, which is another leaflet repair technology. And you can see that in this particular trial, which is much more recent than the TriLuminate study, the reduction in mitral regurgitation was much more striking, with 85% of patients having 1 or 2 plus tricuspid regurgitation. I think the next big step in the leaflet technology arena is the TriClip system. The real advantage of it, the clip is the same, the clip is the XTR clip. The real advantage is that the guide is designed for the tricuspid position. For those of you who are familiar with MitraClip, you'll see that the guide handle has an extra knob which allows you to gain and lose height over the tricuspid valve, which is one of the limitations of using the MitraClip in the tricuspid position now. So that gives you an idea of all of these different technologies. I thought I'd just put this table in, which I think is a really nice sort of summary of the whole situation and how to look at which particular device fits in with which particular pathology. I think extreme dilatation of the tricuspid annulus and pacing leads that are interacting with leaflets are both indications where replacement may be a better option. I wanted to finish by showing you a tricuspid repair case with the MitraClip XTR device that I did with the team at King's and Brompton earlier on this week. So this patient has severe tricuspid regurgitation with a dilated right ventricle, but with reasonably preserved right ventricular function. This shows you the pathology and the reason for the regurgitation. The septal leaflet is very tethered, as you can see. Now, this is the setup we have for the views to carry out a tricuspid repair with the MitraClip system. And the reason that we do it like this is because if you set it up like this with a kind of modified RV inflow-outflow view on the left, and then X-plane through that on the right, which is our grasping view, is the movements of the clip device are then exactly the same as mitral, which makes it much easier for operators and much more intuitive for operators who are used to MitraClip in the mitral position. You can see here that these are absolutely superb images, and you can see here that the leaflets, even with imaging of this quality, are pretty delicate, and you have no chance of grasping them if you can't see them properly. So what we tend to do is put color in the left-hand view, which is the equivalent of a bicommissural view in the mitral repair procedure, MitraClip procedure in the mitral position. So we look at color, we explain through the worst of the color, and that's where we aim to grasp in the right-hand view. So this is the MitraClip steering down over the tricuspid valve. You can see it in 2D and 3D. This is just confirming the position in the aortic and posterior plane on the left and the septal and lateral plane on the right. What you can see in the right-hand image is that the trajectory is really nice. It's perpendicular to the valve as the clip crosses the valve, and it's more or less splitting the color jet. This is the valve open in a 3D on fast view, looking down in the surgeon's view from the top. The septal leaflet is on the bottom left of the image. And what we're trying to do here is grasp the anterior septal leaflet so that the clip is oriented in a 2 o'clock, 8 o'clock position. This is looking in a short axis transgastric view. And if you're looking at these patients, if you're assessing these patients, this is a really, really useful view for the interventionalists when it comes to planning these procedures. A short axis transgastric gives you an idea of the leaflet anatomy, and a short axis transgastric with color really shows us very nicely where the leak is and where we need to concentrate our efforts when it's coming to repair. So if you can give us that image when you're assessing these patients, that is really helpful. So this is the clip oriented over the leak. This is with the grippers down. So we've grabbed the leaflets, but we haven't yet closed the clip. This is with the clip closed. Now, as you often see in tricuspid regurgitation, the first clip doesn't have a huge impact on the tricuspid regurgitation because there's so much redundant leaflet tissue and the valve is so dilated. But what it does do is give us some stability and also makes the second grasp with the second clip much easier. So here's a second clip coming in just a second. Before that, here's the short axis transgastric view, and you can see that the majority of the residual leak, having released the clip, is in the anterior septal commissure. So here we're steering over the top of the valve, getting into the space between the clip and the anterior septal commissure, lining up the clip with similar orientation to before, confirming that with 3D on fast view from above. And this is the clip crossing the valve with the leaflets resting on top. And this is the grasp now with the clip now closed. And that's the final result. So we've reduced severe tricuspid regurgitation down to mild. And as anyone who's looked after these patients will know, these people feel different straight away. One of the real advantages of percutaneous tricuspid leaflet repair techniques is that the procedures are very, very low risk with a very good safety profile. Patients don't feel unwell related to the procedure because it's not particularly deep general anesthetic and it's not particularly hemodynamically challenging. So patients wake up and feel pretty good and almost always are able to go home the next day. So here's the final result, just in a 4-chamber view there. You can see the 2 clips nice and stable with minimal residual tricuspid regurgitation. So that is an overview of the current tricuspid repair and replacement technologies. I think the key points are that tricuspid regurgitation is very common, it's debilitating, and it's very undertreated. The percutaneous tricuspid repair and replacement devices show real promise. I think we have most experience with leaflet repair technologies, which offer a really excellent safety profile, and there is growing evidence for their efficacy, both as the devices develop and iterate, and also as interventionalists and imagers develop their expertise. Thank you very much.